This is a case of laparoscopic Toupet fundoplication. This patient had ineffective motility of the esophagus. So, I am planning for Toupet fundoplication. So, as usual, the left lobe of liver is retracted with the upper epigastric port. You can see my left hand and right hand instrument is coming, that is a from a left lateral port. So, this is the port that I am standing in between the leg, head end in the monitor. You can appreciate around 4 finger breadth above the level of umbilicus. I am making a camera trocar. So, that is the camera trocar. Usually it will be around 8 to 10 centimeter above the level of umbilicus. And now you can see 1 palm breadth distance is there between the xiphoid and the camera port. So, I have a good amount of length between the xiphoid and the camera. And the second port after camera, this is the my right hand working port. It is in the left subcostal plane, right hand working port, usually on the greater curvature of the stomach. And this is the upper epigastrium or subxiphoid. It is right of the midline. So that the entry will be left of the midline, the incision will be on the right of the midline to retract the left lobe liver. So this is my left hand working port in the right subcostal. If we saw the line, transverse line from the right hand working, you can see my left hand working is little down, and then you can see the distance between the camera trocar and the left hand working is less compared with the right hand working, and this is the left lateral port. So, this is the 5 standard port for all cases of transhiatal surgeries we are using. So, this is only one camera 10 mm, all others are 5 mm port. So, liver retracted by any blunt instrument can be used. So, from the left lateral port you can see the grasper is coming, atraumatic grasper. I am holding the stomach, fundus of stomach, and then retracting. So, now I started the division of the gastrohepatic omentum. So, this is the gastrohepatic omentum division. This is a thin patient, and you can appreciate here there is no vessel in the gastrohepatic omentum. There is no accessory hepatic artery. So, since I told you in the first video it is a lateral approach, immediately you can see the caudate lobe is exposed and then right crest is exposed. I'm going up to the diaphragm level. I open the gastrohepatic omentum, and the same peritoneum on the esophagus I am excising. That is the right crest. What I am dividing is the peritoneal covering, not the phrenoesophageal membrane. So, the incision is continued up to the bare area of the stomach. So, starting with the gastrohepatic, it is going around that. Now, I am coming down. You can see the median arcuate ligament. So, I am just opening the fat. So, up to what level the lower fat is there. So, I open the fat. You can see once the fat is open, you can see the nice window is created, the plane is being created. Immediately the structure is the vagus nerve. So, you can appreciate I am lifting the vagus nerve. That is the first structure, that is the posterior vagus nerve. It is above the below the level of hiatus I am seeing. So, you can appreciate I am dissecting the retroesophageal dissection. So, now I am going up. So, now I am entering into the hiatus. You can see the thin layer is covering the hiatus, and I am holding the right crest with my left hand, and I am opening the plane between the right crest and the esophagus. Now, you can see the first structure as I told you before, that is the post-vagus nerve. So, if you are not careful, you will injure the post-vagus nerve here. So, it has to be protected. You can see that is the first structure. So, now I am going up, that is the starting point of the phrenoesophageal membrane. So, I am going to lift the phrenoesophageal, that is the vagus, esophagus. So, I am holding the, so that is the post-vagus nerve, that is the post-vagus nerve. So, now I am lifting the phrenoesophageal membrane. You can appreciate it is like a seat, it is like a seat, and you can see I am lifting the phrenoesophageal with the lower blade of the harmonic, and I am just pushing down the esophagus. I am separating the esophagus from the phrenoesophageal, and that I am identifying the anterior vagus. Now, you can see the anterior vagus now. Again, I am just checking the anterior vagus, so it is seen very clearly. Phrenoesophageal membrane is also like a thin transparent, sorry, it is a white color thick membrane. So now the division of phrenoesophageal membrane is being happen. Now you can see, no, it is a broad membrane. The other name of phrenoesophageal membrane is a inferior diaphragmatic fascia. So the esophageal hiatus, it is like a cap covering, is like a cap on the chest side, that is called superior diaphragmatic fascia. When you are doing esophagectomy, we could appreciate that. And inferiorly, another cap like structure is covering, that is the inferior diaphragmatic fascia. So that is the post vagus nerve, that is the anterior vagus nerve. So abdomen, in abdomen, hiatus is covered with the inferior diaphragmatic fascia, otherwise called phrenoesophageal membrane. So now you can see, once you divide the phrenoesophageal membrane, the anterior surface of esophagus is totally free. Now some posterior attachment is there. So I am dissecting the retroesophageal dissection I started. But as I told you before in the first video, this dissection will not make a window, posterior window. We have to divide the phrenoesophagus. Now we can see that is the again the fibers of right crest joining fibers. Now I am lifting the vagus and the esophagus. Now this is the phrenoesophageal membrane. Can you see this? See, this is the phrenoesophageal membrane. So anteriorly I divided. So this is the posterior phrenoesophageal membrane. We have to divide. Once you divide this membrane, then only the window is open. Then only we can claim that we are mobilizing the lower esophagus. So if you not divide, and then if you are doing a fundoplication with the remaining fundus, that means your wrap will be on the OG junction or on the stomach. Lower esophagus mobilization is complete only by dividing the phrenoesophageal membrane. Now you can see the window is automatically is done, created. So now I am dividing other facial attachment. Now spleen is seen. So now it is a lower esophagus is completely mobilized, that is the OG junction. So I am going to apply a tape. So it took only 10 minutes time to mobilize the lower esophagus. That is the first step is gastrohepatic omental division, then peritoneal incision, then retroesophageal dissection, then identify the hiatus, then entering into the hiatus. So now I tied the tape around the lower esophagus. I tied the tape around the lower esophagus. So now I can give a traction. You can appreciate, no, it is coming out. Esophagus is coming out from the mediastinum. So this much traction you cannot give by holding the stomach or holding the esophagus. So this is the right pleura. Right side pleura is seen nicely. So again I have to separate the pleura from the esophagus so that the mediastinal dissection is being started. So that is the mediastinal dissection. You can see the node, lymph node in the mediastinum. So the pleura should not be injured. We have to be careful. So I am just opening the thin layer. No, I am just pushing the pleura from with my left hand. I am opening the thin layer. So if you are going in a layer, identify the plane. You can see the vessels is going away when you are dissecting it. It need not to coagulate all the vessel, and we need to mobilize the adequate length of esophagus without compromising the. So that is the post vagus now. So these are all the adhesions we have to release. So very thin. I am not holding a thick tissue. I am holding only the thin tissue. Now you can appreciate the mesoesophagus. I am pushing the mesoesophagus towards the esophagus. So that fat is called mesoesophagus. I am pushing it towards the esophagus. Small vessel I am coagulating. Now you can appreciate the thoracic aorta. That is the thoracic aorta is seen very clearly. Thin layer is covering the thoracic aorta. Just I am opening that layer. Very slow and gentle dissection is required. So now posteriorly it is done, right side and posterior is done. I am going for anterior. So the transhiatal mobilization we have to start with right side, then posterior, then anterior, then on left side. We need not to remove this node. and you can see all the vessels is seen over the esophagus, but is not injured. And any tubular, any structure you want to divide, confirm with the vagus nerve and then divide. See, that is the vagus nerve. It's easy to injure of anterior vagus and posterior vagus. So we have to be careful. So now I am lifting, retracting to the right side, and you can see here I am taking the attachment of the esophagus from the left pleura. So this here also the pleural injury is common. So we have to go carefully close to the esophagus, and if you have not, see, like this is separate, give adequate traction and then divide, so that your energy device will not injure the pleura. So that is the fibers of reflected fibers of right crest. I am retracting with my left hand instrument, and then I am separating the esophagus from the reflected fibers of right crest. So now almost entire esophagus is free, and if any post attachment is, that is a big window created for a fundus of stomach. So again you can see that is aorta. So left side is also free. So all around it has to be freed, and if you pull the esophagus, there should not be any structure attached to the esophagus. Here that is small structure is there. So again vagus is there. See, that is the vagus. It's going. That is the anterior vagus, right crest, left crest, median arcuate ligament. Down will be the aorta. So that is the thoracic aorta. So that is the right side pleura. So here I want some more division of these fibers, and I am not taking a thick tissue. I am taking a thin, and I am this side you can see by retracting you can see very thin fiber attachment. See, thin attachment. Now all this thing make it very thin and then divide, so that bleeding will not be there. Like this, no, we can go around 5 centimeter, even at 10 centimeter, like this we can go. In some cases we do transhiatal esophageectomy like this. So now we can say adequate length, more than adequate is dissected. That is the right crest, esophagus, thoracic aorta. Both right crest is seen, thoracic aorta and esophagus is seen. And here some attachment is still there. Now you can see the peritoneum, retroperitoneum. I am attaching the, taking the fundus of stomach from this posterior retroperitoneal attachment. You can see the anatomy, it's very clear anatomy and good exposure. Even in obese patient also we can make it like this. And only thing you have to go in a step by step manner, and don't hold the tissue. See, if you have a harmonic scalpel, doesn't mean that anything you can catch and then you can coagulate, it won't bleed. So it is not like that. You have to go in a plane, identify the structure, and if you want to coagulate, skeletonise the blood vessel and then hold the blood vessel in a harmonic scalpel in a perpendicular way, then divide. So these are all the thing is matter for a bloodless clean dissection. So now I going for a fundus mobilization. This patient looks like a very short fundus. So fundus mobilization, the greater curvature, and this is, you have to go close to the stomach as much as possible, not to injure the heat, should not injure the stomach, or you have to come 5 mm or 7 mm distance, but since adequate traction is there, so even no need for 5 mm, even if you go close to the stomach is enough. Only thing, adequate traction is good. So now I am hold the post wall of stomach, and I am not taking leaving a much tissue on the stomach side, you can appreciate. So that is a small vessel, branch vessel. This is the, now I am going for a bigger one, short gastric vessel, and my left hand lateral port is retracting the post wall of fundus of stomach, and I, with the right hand also, left hand also, I am just exposing the structure. So before division of the any short gastric, expose nicely and then divide. So it is divided. So now I am coming on this side. So these are all the loose area, small thin layer of tissues to be divided. You can see on both sides alternatively. You are seeing the anterior and posterior view like. So, again I am coming on this side, still some attachment is there. So, I am taking that attachment. So, we have to entire fundus should come to the right side, and we have to see the reflected fibers of right crest, from upper top to bottom. Then only we can claim that it is a fundal mobilization is adequate. And usually we divide one short gastric, sometimes two, and then post gastric. Then we fundus mobilization will be adequate. So, these are all small attachment to the hiatus, to the hilum, not hiatus, hilum. See, it is completely coming out. So, now I am checking the adequacy of the mobilization of the fundus of stomach by taking the fundus on the left side. See, if I leave it, it has to be stay there. And another test is, it's called Suicide maneuver. Suicide maneuver, lift the esophagus, don't press down the esophagus. I'm doing a suicide maneuver. When you are doing a suicide maneuver, you have to see the esophagus. Esophagus should not rotate. If esophagus is rotate, that means the post attachment is there. It is not that you can able to move the stomach is not a matter. You have to watch the esophagus, lower esophagus when you are doing a suicide maneuver. There should not be any movement of the esophagus. That is a rotation of the esophagus should not be there. I could see minimal rotation. That's why I'm doing it this small dissection posteriorly. So now I started approximation of the crura, and now you can see there is a left crest. Sorry, again it's coming in my mind left crest. So now we started crural approximation by approximating the both the fibers of the right crest. So it is both right crest only, because in the right crest the esophageal hiatus is there and the hiatus is widened. So I am approximating it with the 1,0 polyamide suture, that is ethylene suture, otherwise called nylon. So again I keep the left hand instrument between the aorta and the crest, aorta on the right crest, so that aortic injury is prevented. And again taking here, compare with this right side fibers is little thinner, but left fibers on the other side is thicker. So crural approximation I feel it is a good one. There is no need for any mesh repair for this patient. So I am pushing the knot to one side, not keeping the knot in the center, and I am taking a third suture. And usually I used to feel the needle, no, with my left hand, tip of the needle with the left hand, it touching the left hand and is coming out. Rotate and then take. So now I leave the esophagus, the empty esophagus is occupying the hiatus nicely. So that is enough. There is no need for that close. That closer will make a tight of the esophagus. So if you leave the esophagus, it is occupying the hiatus. That means it's correct. So now I am started taking the fundus on the other side. So now one side, left side is the anterior part of the fundus, right side is the post wall of fundus. As usual, all the patient had this fat in the OG junction. If you exercise the fat, then your fundoplication will be, approximation will be adequate. Always, when you are exercising the fat, don't go close to the esophagus or stomach. That will injure the vagus nerve. So, I am taking the fundus. You can see, no, I'm pushing the fundus towards the diaphragm, so that you have to take the fundus up towards diaphragm and then you have to make a wrap, so that it will increase the angle of hiss. So, that is the main control of reflex prevention. See, I am taking the fundus up and then I am making a wrap. I am not wrapping just close to the OG junction. You have to take the wrap. So, it will narrow the angle, so the reflex control is good. So, I am taking, since I am planning toupet, you can see I am taking the anterior wall of the esophagus. I am not taking the lateral wall. If you take the lateral wall, it's become a 180-degree fundoplication. That is a regular toupet. This is a modified toupet fundoplication. So, even if you take anterior layer, after that, no, it will give some gap. So, again I am taking a anterior layer. I leave only around 7 mm gap between the suture. So, here I am taking a stitch. See, it is bleeding, no, since it is close to the vessel, it started bleeding. So, what happen if it bleed means, hematoma will form. So, you have to press that area for some time. So, first suture, tight the suture, press it, so it is stopped. Again I am taking a anterior wall of the esophagus. Again the post wall of fundus of stomach. Many surgeons, they are doing um, toupet fundoplication, modified toupet for all case of fundoplication, even in a normal motility of esophagus. But in my unit, our protocol is ineffective motility toupet, normal motility Nissen fundoplication. So, what I am telling is, don't hold there and then lot of fundus will be wasted, that will not give effective reflex control. So, you have to give the posterior to the esophagus, the fundus should be adequate, it should not be very loose fundus. So, don't that's you adequately assess and then take the fundus. So, again you can appreciate, now I am taking anterior wall of the esophagus. So, usually 3 stitches, no, 3 centimeter of fundoplication, length of fundoplication. So, 3 stitch we used to take. This stitch will be center stitch on the left side. I am going to make up above one, below one. So, above. Now, you can appreciate, the post fundus, the fundus on the post surface of esophagus is adequate, it is not very loose. See, again take the anterior wall of the esophagus. Don't take the lateral wall, that will it become a 180-degree fundoplication. It is not a 270-degree. We need a 270-degree fundoplication for effective reflex control. So, again I am taking a lower stitch, interval of fundus to the esophagus. So, this completes the 270-degree toupet fundoplication. And during this step, vagus is not injured because it is going laterally. So, now I am checking usually this 6 stitch will hold the fundus, it will not give any traction, but anyway, we will take the post wall of fundus to the right crest. It will keep the fundus on the right side, that is the first purpose. Second purpose is, it will prevent the transmigration of the wrap into the esophagus. Don't take very thick in that area, it will injure the aorta. So, we have to take only the some fibers of the right crest. So, this stitch completes the laparoscopic modified toupet, that is 270-degree fundoplication. So, I remove the cotton tape now. Now, you can appreciate the adequate intraabdominal esophagus, and that is a toupet fundoplication, and there is no increased size of that bleeding pus hematoma. So, it is all stitch 3 stitch on each side is taken, hiatus is also adequate. So, the lie of the stomach after fundoplication should be like this, there should not be any rotation. So, with this the surgery is over. Thank you so much.